Welcome everybody to Regional Pharmacy Journal Club for February. I'm Heather Naylor, the Regional Pharmacy Education and Research Coordinator. So thank you to everybody for coming out today. I'm pleased to introduce you to one of our fourth-year pharmacy students, Jimmy Lee, who was brave enough to take on a regional journal club. Very much appreciate you doing this. So Jimmy is from Hampton, New Brunswick, and he's currently at the regional for his hospital rotation. He's done 3 weeks on cardiac surgery and is now finishing up 3 weeks in the anticoagulation clinic. But today, Jimmy will be talking to us about the Dapa Hf trial that's been making headlines lately. So I will hand it over to you, Jimmy.
Thanks, Heather. So, hi everyone. Like Heather mentioned, my name is Jimmy, and I'm going to be presenting on the Dapa Hf trial, which came out not too long ago. So, it's just some of the learning objectives for today. We're going to describe the study methods, patient population, look at the key findings from the study, and we're just going to critically appraise the study, look at its external and internal validity, and if this result can be applied to just some of the patients. And then we're also going to see if we can actually integrate what the study found into our practice, and we'll go through a patient case at the very end. So this is fictional patient, Mr. HF, 69-year-old male, 92 kilograms, 162 centimeters tall. So patient medical history, so significant for class 2 heart failure, diagnosed in 2020 with an ejection fraction of between 30 to 35%. Dyslipidemia, diagnosed 2 years ago. Vitals look good. Lipids also look good. And then just some of the other pertinent lab values. So serum creatinine, 175 micromolar. A1C is 5.9%. And some of the medications that the patient's on, so statin, ACE, beta blocker, and spironolactone. Yeah. So just a quick overview of what Mr. HF's creatinine clearance is. So, if a patient if their actual body weight is greater than their ideal body weight, 30% or more, then we use an adjusted body weight. So for males, this is the equation that you use for ideal body weight. So 50 kilograms plus 2.3 times every inch over 5 feet. So because he's 162 centimeters, he's, I think, 5'3", so we times it by 3. So his ideal body weight is 56.9 kilograms. So yeah, because it's definitely lower than, or his actual body weight is definitely 1.3 times bigger than his ideal body weight, we're going to use his adjusted body weight. This is just a simple calculation. We use a correction factor of 40%. To calculate his adjusted body weight. So his new adjusted body weight is 70.94 kilograms. And when we plug that into the creatinine clearance equation, we get a creatinine clearance of 34.5. So yeah. So I'm going to be talking about the SGLT2 inhibitors because Dapa Hf looked at dapagliflozin and its role in heart failure. So when dapagliflozin was initially introduced into the market, it was used for that type 2 diabetes. So basically the mechanism of action is that it acts on the proximal tubule in the kidneys, and it basically inhibits the sodium glucose transporter. So what that transporter does is that it reabsorbs the glucose that's filtered through the kidneys. So dapagliflozin, empagliflozin, canagliflozin, they basically block this transporter to inhibit the reabsorption of glucose, so you can excrete the extra glucose out of your blood and into urine. So, and just looking at the mechanism of action of dapagliflozin, it's really important that the patient has normal renal function, because where it acts on the nephrons, if a patient has decreased renal function, then there's significant risk for accumulation of the drugs within the kidneys, which could lead to adverse drug events. So this was the main trial that basically brought dapagliflozin into the market. So it was looking at type 2 diabetics using dapagliflozin, different doses, so 2.5, 10, 5 milligrams compared to placebo. And just looking at the results, placebo only decreased A1C by 0.3%. And as you go up the dosage forms, so 2.5, 5, and 10, we see fairly linear decrease in the A1C, and we can see that they're all statistically significant compared to placebo. Also, the study found that dapagliflozin has a statistically significant increased risk of genital infections. But it also didn't find any increased risk of hypoglycemia. So this was another really important trial that gave us more information about the safety and the efficacy of dapagliflozin. So it looked at a lot of type 2 diabetics and normal renal function. They've got atherosclerotic cardiovascular disease. So they basically looked at dapagliflozin 10 milligrams daily, and that was added on to whatever anti-hyperglycemic therapy they were on, except the thialinidinones. Does anyone know why those were excluded from the trial? So basically, rosiglitazone, pioglitazone, when they came out on the market, they found that it could increase heart failure exacerbations. So there's just a lot of cardiovascular risks associated with those medications. So that was the main reason why they excluded those patients. And they compared it to placebo. So basically, they found that they lowered the rate of cardiovascular death or heart failure hospitalization. And we see that the p-value is 0.005, so it's statistically significant. And it's also exemplified in the 95% confidence interval. This study also found that dapagliflozin has a higher incidence of diabetic ketoacidosis, and that is a fairly severe adverse drug reaction. So that's just going to build nicely into the Dapa Hf trial. But before I go into that, there's a lot of hypotheses on how these SGLT2 inhibitors work. So there's just some thoughts that it can help have cardiovascular benefits by improving the cardiac metabolism. And also there's the sodium hydrogen exchange that's cardio-specific in the heart, and basically that has been shown to be beneficial in heart failure. It also reduces necrosis in the heart and cardiac fibrosis, and so on. So basically, this is the Dapa Hf trial. It was published in the New England Journal of Medicine, fairly reputable journal, a really good journal. High impact factor. It was called dapagliflozin in patients with heart failure and reduced ejection fraction. And the trial was sponsored by AstraZeneca. Does anyone have any idea why they funded this trial?
Did they make a product for that?
Yeah, so they did make the product. So they were the major sponsors of this trial. Do you guys see any problems with Big Pharma funding like massive trials like these?
It's biased.
Yeah, so bias for sure. There's a fine line between whether funding is ethical or not from Big Pharma companies, because if they find something good about their own medication, then that just basically provides great profits for them. Like if they can get like a Health Canada approved indication, like a new one, they're going to be able to sell the product more. But it's hard because no one else is going to fund massive trials because they cost millions of dollars, and realistically, big pharma is the only people that can fund these trials. It just depends on their involvement, whether they're involved in writing, the procedures, if they're doing statistical analysis, and so on. Yeah. So Dapa Hf, it was a randomized placebo-controlled trial, phase 3, multi-centered, so it was all throughout the world. So Canada, US, parts in Asia, Europe, and South America. So why is this research question relevant? So why is it important that they looked at dapagliflozin in heart failure? And that's because of the DECLARE-TIMI 58 trial that found benefits in cardiovascular death and reduced hospitalizations due to heart failure. So they, dapagliflozin, it's a type 2 diabetic medication, but how is it beneficial in patients with just heart failure? So it's a really cool finding, and to be able to apply this medication to non-diabetics, there's room for novelty and great application. So the study population for this trial, there's some inclusion criteria. So they had to have class 2 to 4 heart failure with reduced ejection fraction. So they can't have preserved ejection fraction. So they had to have an ejection fraction of less than 40% over the age of 18, and some biomarker criteria. And important thing is that they had to have been optimized and stable on their heart failure medications for 4 weeks or greater. So I just included a small table that was in the CCS guidelines for heart failure. It basically looks at the NT-proBNP levels for heart failure. So I'm just going to quickly go into what that is. What is NT-proBNP and why is it relevant in Dapa Hf? So basically, this biomarker, it's released when the heart's under a lot of stress. So when there's a lot of stretching, basically this molecule is released. It's cardiospecific. The NT-proBNP, and those we usually test those levels in heart failure patients to see if they're having an acute exacerbation and whatnot. So basically, in heart failure, this molecule it's transcribed and then it's produced, and then there's BNP, which is the active version. So it increases cBNP, and that promotes smooth muscle relaxation and causes vasodilation, and to hopefully improve perfusion throughout the rest of the body. So this is from the CCS guidelines as well. So this is the regimen for heart failure. So depending on what class that you have, that kind of dictates what medicines that you should be on. So as soon as someone presents with heart failure and they're diagnosed with heart failure with reduced ejection fraction, they should be started with triple therapy. So an ACE or an ARB if they can't, or an ARB if they can't tolerate the ACE, beta blocker, and something like spironolactone. And so you want to titrate them up to the max tolerable dose. And if they're still symptomatic, then you're gonna explore other options. So based on their vitals, you can add ivermectin, and Usually the next step is to switch the ACE or ARB to an ARNI, so something like Entresto. Yeah. So we're also going to look at the exclusion criteria. There's a big list, and we're going to be talking about that at the end. But basically, anyone with type 1 diabetes, they're going to obviously be excluded because you can't use SGLT2 inhibitors in type 1 diabetes. And other things. So yeah, if they have decreased renal function, they're going to be excluded because, like I mentioned, SGLT2 inhibitors, they're contraindicated in poor renal function. And yeah. Okay, so this is the PICO for the Dapa Hf trial. So basically, 4,700 patients with class 2 to 4 heart failure, and mean age was 66.5, and a majority were male and Caucasian. So they investigated dapagliflozin 10 milligrams daily versus placebo, and some of the primary endpoint that they assessed was worsening heart failure, and how they described worsening heart failure was hospitalization due to heart failure, or urgent visit requiring IV therapy for heart failure, or CV death. So this is just the patient demographics of the study population. So yeah, 66. Do you guys see any problems with the percentage of females that were included in the participants? So there were about 23 point whatever percent were females. Yeah, so heart disease doesn't discriminate between males or females. I know in the news recently they were the Heart and Stroke Foundation, they were emphasizing that women are just as likely to experience heart disease, and they're not. It's harder for women to actually be hospitalized because a lot of practitioners won't really take their complaints seriously, or it's hard for them to actually verbalize their symptoms and go to hospital for them. So, yep. In terms of the study population, geographically, most of them were European, and very few were North American. So, yeah. And when you look at their classes, most were class 2, and as you move up the classes, very few were class 4. So they had very few had the worst heart failure class. Yeah, so just some more patient demographics. Most of them had, decent renal function. And when you look at diabetes, so around 41.8% had diabetes. So that was really good with the Dapa Hf trial because they were looking at how dapagliflozin affects non-diabetic patients to see if these people with if they don't have diabetes, if this medication is actually truly effective at improving heart failure. So, yeah. Yeah. So continuing on with the patient demographics, around 77% were on the triple therapy, so it's good. We see that the beta blockers and the ACE or ARBs, they add up to around 90% of people were on these two essential medications. But we also see that because of the spironolactone, the MRA, that brought down the average a bit. So most of the patients in the study, they were on the triple therapy. So I'm just gonna I'm gonna go over the results. Some pretty cool findings. So the primary composite outcome, it was based on CV death hospitalization for heart failure or an urgent visit requiring IV therapy. So when we look at the incidences of those, we see that with the pagliflozin 10 milligrams, 16.3% of the patients experienced the primary composite outcome, so CV death or hospitalization. Whereas placebo, there were 21.2%. And you look at the p-value, it's less than 0.05, which is usually the standard for statistical significance. And yeah, we see quite a statistically significant difference between intervention and control. So these were just the secondary outcomes, CV death or heart failure hospitalization, the change in KCCQ. So what that is, it's just it's like a subjective questionnaire that assesses the patient's subjective experience with the heart failure, whether they're experiencing symptoms or not. And we just see that it does a good job at changing the KCC score after 8 months. Another important finding, worsening renal function. There was no statistically significant difference between the intervention and control, and that's really important to reiterate that these medications don't make your kidneys worse. It's just that because of the findings from the declared TIMI trial with the diabetic ketoacidosis and genital infections, that if they have poor renal function, then it's you're at risk of accumulating the metabolites and thereby causing more DKA and genital infections. And just some lab measures. So it significantly decreased NT-proBNP levels. A1C, it decreased by a lot, or not a lot, but it decreased more so than placebo. So all these findings were statistically significant. These were just some Kaplan-Meier curves with the primary outcome. If you see on the bottom parts of the graph, they don't look that big, but there's a zoom-in version in the middle. So you see the blue line represents the pagliflozin, and the red line represents placebo. And on the y-axis, we see the incidence, and on the x-axis, it increases with time. So with time, we see that there's a decreased incidence of the primary outcome compared to placebo and the hazard ratio. So we can interpret it as, there's around there's a 25% or 26% decrease in the primary outcome. So heart failure-related hospitalizations or CV death when you're taking the pagliflozin compared to placebo. So this is just another visual. So CV death, it was a really cool finding because before we had this trial, with the SGLT2 inhibitors, we had mostly evidence behind empagliflozin and canagliflozin. So when you look on the diabetes guidelines in Canada, if a patient has CVD, the two SGLT2 inhibitors that they recommend is empagliflozin and canagliflozin. But now with the new findings with the CV death, maybe the pagliflozin could be included in the diabetes guideline. So I'm just gonna get you guys to participate. I don't know if you guys remember how to calculate NNTs, but it's a very useful very useful tool to explain to patients about the benefits of these medications. So we're just going to do it for the primary outcome. So placebo, there was an incidence of 21.2% compared to the pagliflozin, which was 16.3%. So just give you guys a couple of seconds to calculate. And if I have any volunteers, it's okay to be wrong because I'll show you how to calculate it. 20. Okay, so we've got some 20s. Anyone else? 1,000? Oh, no, never mind. 220? One? No one? Okay, so we'll go with 20 for now. So I'm just going to show you how to quickly calculate the NNT. So you're going to find the ARR. So you're going to subtract placebo incidence with the dapagliflozin incidence, and we get ARR of 4.9. And to calculate the NNT, we 4.9%. So we divide 100 by the ARR, so we get 20.4. But because we're dealing with people, we have to round up. So the NNT for the primary outcome was 21. So, like I mentioned, the NNTs are a really good tool to explain to patients about the benefits of this medication. So, as illustrated here, there's 20 neutral faces and 1 happy face. So basically what that means is that for every 21 patients who's treated with dapagliflozin 10 milligrams daily for 1.5 years, 1 patient with heart failure will avoid worsening heart failure when compared to placebo. So, yeah. So I'm just going to quickly go over the safety outcomes of the study. So, long story short, there were no statistically significant differences between intervention and control. So it didn't show an increased risk of hypoglycemia, and that's well evidenced in the literature. Diabetic ketoacidosis, there were 3 people that experienced that DKA compared to placebo. So there was an increase in that. So since you guys calculated the NNT, I'm going to get you to quickly calculate the NNH for DKA. So so they're 0.1% and 0 for placebo. So what do you guys think? I'm just going to tell you, it's NAD. Because there were no events in the placebo, you can't use
Dividing by 0.
exactly. Dividing by 0 mathematically doesn't exist. So that's a great catch. That's my main point. So if there's no events in any of the arms, you can't use NNT or NNH. Oh, okay. Subgroup analysis. So they divided the patients based on, some of their different demographics. So, So here we see that with the non-diabetics, we see that the hazard ratio is 0.73, and the line of no difference is 1. So with these forest plots, if the 95% confidence interval crosses 1, then that means it's statistically non-significant. So in terms of non-diabetics, we found that it's quite statistically different, or statistically different compared to placebo. So that was basically the main finding of this trial. So in summary, dapagliflozin has statistically significant different benefits in terms of worsening heart failure or CV death, irrespective of whether the patients have type 2 diabetes or not. And there were no statistically significant differences between intervention and placebo in terms of ADRs. So just some study strengths that I thought of. Who would have thought to use a diabetic medication for heart failure patients? So it's a very novel application of fairly new drug. And in terms of external validity, I put a question mark there because, like I mentioned, a majority of the patients were on triple therapy. That was good. And they they replicated all the results by a university in Europe, I believe. And so yeah, that just adds to the fact that there is probably less bias because, like I mentioned, AstraZeneca, they basically did all the analysis, but when you get an independent academic group to replicate the results, it just adds to the external validity. And yeah, they're concealed. In terms of the limitations, external validity in big font, can you really generalize these results to the patients, the real-life patients? And when we looked at the exclusion criteria, there were a lot of them. So how can you really apply these to real-life patients? Duration of the trial, 1.5 years, so it wasn't as long, and trial sponsor, like I mentioned. So back to Mr. HF. Does he fit into the exclusion criteria? Yes, he does. So in conclusion, can we give Mr. HF dapagliflozin? So I'm just going to skip this question. In the States, the FDA approved dapagliflozin for type 2 diabetics based on the DECLARE-TIMI trial. So hopefully we see those changes in Health Canada. But there's a big issue with coverage. So with the NB drug plans formulary, basically it's only covered if the patient has type 2 diabetes. It has nothing about heart failure. And when you look on the NB Hospital's drug formulary, the dapagliflozin is only given if the patient's been on it before. No mentioning of heart failure or not. So there's some big barriers to taking dapagliflozin. But yeah. So if the provincial drug formulary covers dapagliflozin, it's around $325 for around a bit more than 3 months. Is there an economic benefit in reducing worsening heart failure? So is it is it more economically feasible to cover the medication compared to, the costs that are associated with hospitalization? So there needs to be more studies, economic benefit analyses in that regard. So yeah, hopefully we see FDA and Health Canada approval for dapagliflozin being used in non-type 2 diabetics. So yeah, that basically concludes my presentation. If anyone has questions, feel free to shout them out. Thanks.
So, kind of goes to your question. If you had a new patient with heart failure who was non-diabetic, they've had heart failure, they've had a worsening, they're on triple therapy, and they did a new medication, you pick dapagliflozin or no?
So the question was, if I had a new patient and they had heart failure and they were on triple therapy, would I give dapagliflozin or Entresto? I'd give Entresto. Because it's best to optimize patients on triple therapy. Entresto basically, it kind of replaces the ACE and ARBs. And it's more, it was marketed for heart failure. I can go over like the mechanism of action of Entresto, but long story short, it's just more evidence in terms of benefiting patients with heart failure. Thanks for the question. Yes?
When I read through the study, it seemed to suggest that patients in class 3 or 4 were less benefited.
Yeah.
Did you agree?
Yeah, so the question was on looking at the results, so the subgroup analysis. Class 3 and class 4 patients, it seemed like they didn't benefit as much from the dapagliflozin. And I'm just going to quickly go over to that slide. So at first I thought about that, is it really beneficial in those patients? But when you look at the subgroup analysis, you know, the results for those patients, you know, there is, oh, wait. Yeah, so they do cross the line of no difference, right? So if they're in class 3 or class 4, you know, the 95% confidence interval crosses 1. But when you look at the overall numbers, so the sample size, only 767, around that number, had class 3 or class 4. So when you're trying to do subgroup analyses with such small numbers, you know, you're going to find anything, really. And for every like analysis that you do, you need to have the correct power and whatnot. But when you're using such small numbers, you know, the sample size might not be properly powered. So just because we see non-benefit, non-statistically different benefit with the pegliflozin compared to placebo in this specific patient population, you can't really take that to heart because the sample size is just so small compared to class 2, where there's the majority of patients.
And your risk is minimal to negligent, right?
Yeah, exactly. So,
Thank you.
no problem.
Jimmy. Just check in with our satellite site. Does anyone have any questions for Jimmy? Might be off the hook. Awesome. So thank you so much, Jimmy, for a great presentation. I'm going to send out an online evaluation for Jimmy in a couple of minutes once I get back downstairs. So if you have a few minutes this afternoon, please fill it out. And Mia will review with Jimmy tomorrow for his evaluation. So we'll see you guys in a couple of weeks for pharmacy grand rounds. And we have a pharmacy technician from Calgary who will be Skyping in to talk to us about her experience with the opioid epidemic. So please attend if you can. Thanks, everyone.